I think that's probably better that way than the other way. So, sticking with the theme of early diagnosis, how are we in practice going to achieve that? Well, a lot of this goes around education, doesn't it, in terms of the general public, in terms of doctors in primary care, general practice, so that these patients are fast-tracked to a specialist unit. And this process has been much facilitated in the UK by early arthritis clinics, and we've started up one recently at Basingstoke, for example, whereby we've sent instruction and appropriate forms to be completed by primary care physicians with specifications to what patients require to be referred to that clinic. And in essence, this can be synovitis in more than one joint for 3 months or more, or involvement of the hands or feet, or a positive rheumatoid factor or anti-CCP antibody. So that one is going to get patients who obviously haven't got rheumatoid arthritis, but given the expertise available at the receiving end, you should be able to pick up these patients without too much difficulty. Tight controls, I'll say later, has become an important part of this process. In most early arthritis clinics and in ours, we built in the facility whereby we can see these patients on a monthly basis. Many of the visits are done using rheumatology practitioners. Consultant expertise is obviously not always immediately available. These individuals are highly skilled and well capable of helping to run such a rheumatology service. And with tighter control, we can make a huge difference to getting these patients on the right treatment early and adjusting that treatment as appropriate. So I'm sorry, there's some repeat in some of these slides. The Cora study, you've probably heard quoted many times. This is a study done by Hilary Capel's team in Glasgow before, 10 years back or so, looking at the advantages of tight control with conventional means of treatment. And it became clear as a result of that work that rather than treating these patients conventionally, that if you see them every month, adjust their disease-modifying drugs appropriately, introduce combination therapy where possible, and upstep that where appropriate. At the end of the day, not only are they much better clinically, but there's far less progression in terms of disability and X-ray progression. And it's this that's fed into the early rheumatoid arthritis clinic movement. This just repeats what I've said earlier. Those patients with insidious disease, it can be very difficult. So having said that we need to diagnose early and that we need to treat early, and it really does make a big difference, it's a bit like treating cancer, get these patients into remission quickly and they will do much better in the long term. How are we going to treat them? It remains a challenge to know how best to treat such individuals. Some patients, probably the minority given the evidence we have now, may respond to single therapy, treatment with a single disease-modifying drug. Most others should be treated with combination therapy, we know as a result of evidence that's come through in the last few years. The initial HAQ score is the best predictor of future disability. I mean, the question is, how do we pick out those who really do need aggressive therapy amongst that large cohort that you're going to get referred into the clinic? Well, a HAQ score is useful. The height of the rheumatoid factor and anti-CP is useful. The number of swollen joints at diagnosis is useful. Those others with the worst prognosis are women, particularly elderly women and teenage girls. Insidious onset, poor prognostic sign. Presence of a normochromic normocytic anemia, and obviously early erosive change on X-ray. So what are the options? Well, monotherapy, I wasn't going to dwell on, as most of you will be familiar with that. Combination therapy is really the best way forward. And this can be given in several ways, either step-up treatment, sequential adding in of disease-modifying drugs, step-down treatment, which produces best results. That introduce 2 or 3 conventional disease-modifying drugs with steroids as well, which are tapered down, or parallel, start everything and continue for quite some time. So monotherapy in milder cases, occasionally hydroxychloroquine is useful, but most of the time you're going to be using methotrexate or sulfasalazine. As you'll know, methotrexate has largely replaced the other two in terms of efficacy. and rapid titration up, starting a dose of 10 to 15 milligrams once a week, up to a total of 20 to 22.5 milligrams a week, is the best way forward. And you'll know that side effects are not uncommon in terms of nausea, for example.